Welcome to The Explainer. We hear it all the time. People casually tossing around the phrase, oh, I'm so OCD, just because they like a tidy desk or a perfectly color-coded calendar. But today, we're going to look strictly at the clinical science to show you why that casual everyday phrase couldn't be further from the truth. We are totally unmasking obsessive-compulsive disorder to understand what it actually is, both biologically and psychologically. Here's our roadmap for this explainer. We're going to systematically demystify OCD. We'll start by moving past the idea of just being neat, dive into the vicious cycle it creates, peek inside the underlying brain biology, figure out how it's officially diagnosed, and finally, look at gold standard treatment options and real patient outcomes.
So let's jump right in and look way beyond just being neat so we can understand the harsh reality of OCD.
We absolutely have to start by shattering some common myths right out of the gate. There is a massive, stark contrast between everyday tidiness and a genuinely debilitating medical condition. On one side, sure, we have normal habits. Some of us are naturally organized or maybe a bit perfectionistic, right? But on the other side, we have true OCD rituals. These aren't just quirky preferences. They are extreme behaviors that significantly interfere with a person's work, their education, their relationships, and just their basic ability to function day to day. To really grasp what patients are going through, we first need to define the O in OCD, obsessions. These are deeply intrusive, completely unwanted thoughts, images, or urges. Imagine having an intense fear of contamination, a completely paralyzing dread of making a mistake, or overwhelming religious and moral fears, which is known clinically as scrupulosity. Now, patients themselves usually recognize these thoughts as irrational, but the catch is, they still cause profound, overwhelming distress. Then comes the second half of the equation, compulsions. These are the exhausting acts that people feel literally forced to perform just to neutralize those terrifying obsessions. We're talking about repetitive behaviors like excessive hand-washing to the point where their skin might actually bleed, repeatedly checking locked doors, or arranging objects perfectly symmetrically. Sometimes they are even unseen mental acts. And they do this for one reason, to desperately reduce their anxiety or prevent a feared disastrous event. Now, how do these obsessions and compulsions lock a person into such a relentless loop? Well, it's essentially a vicious cycle. It plays out in 4 exhausting steps. First, bam, an intrusive thought hits and triggers massive distress. Step 2, the person's anxiety violently spikes. Step 3, to escape that intense psychological pain, they perform the compulsive behavior. And step 4, they finally feel some temporary relief. But here's the ultimate trap. That relief is incredibly fleeting. The intrusive thoughts always return. And because the brain basically learned that the compulsion provided a quick fix, the disorder's grip is actually reinforced and made stronger over time. Which brings us to what's going on inside the brain itself, the underlying biology. What's really fascinating here is looking at the physical misfires that prove this is a real medical condition, and absolutely not a personality flaw. Our medical understanding has actually evolved drastically. Decades ago, this was just viewed as a historical psychiatric diagnosis. Then, by the mid-20th century, we saw the development of cognitive behavioral therapy, followed by the introduction of serotonin-based medications later on. Fast forward to today, and our understanding is driven by incredible modern neuroscience and highly detailed visualizations of the brain's actual circuitry. The crucial takeaway from that modern neuroscience is that OCD is deeply rooted in abnormal activity within very specific brain networks. The big one is called the cortico-striato-thalamocortical, or CSTC circuit. It involves areas like the orbital frontal cortex, the anterior cingulate cortex, the basal ganglia, the caudate nucleus, and the thalamus. When these parts don't communicate properly, the brain basically gets stuck in a worry loop that it literally cannot physically turn off on its own. But it's not just the hard wiring that's off. It's the chemical messengers, too. Alterations in 4 key neurotransmitters, serotonin, dopamine, glutamate, and GABA, completely disrupt the brain's normal signaling. When you combine those brain circuit abnormalities and chemical imbalances with things like genetics or severe environmental stress, you get a perfect biological storm. With all of that complex neurobiology in mind, you might be wondering, how do doctors actually diagnose this from a scientific standpoint? Interestingly, standard MRI scans aren't routinely required unless they suspect another specific neurological issue. Instead, doctors rely heavily on a really rigorous diagnostic protocol. They conduct comprehensive psychiatric interviews, detailed mental status examinations to assess the patient's level of insight, and they use specialized, highly accurate tools like the Yale-Brown Obsessive-Compulsive Scale, or YBOCS for short, to objectively measure the severity of the symptoms. A huge part of this diagnostic phase is telling the difference between true OCD and OCPD, which stands for Obsessive-Compulsive Personality Disorder. True OCD is characterized by completely unwanted, deeply distressing thoughts. OCPD, on the other hand, involves really rigid personality traits and a need for order, but the person generally doesn't find their own extreme rigidity distressing. Distinguishing between the two is a vital step for getting the treatment right.
Okay, let's move into the most hopeful part of this explainer, the evidence-based treatment options that actually break the cycle.
While general cognitive behavioral therapy is definitely helpful, there is an undisputed gold standard for OCD, and it's called exposure and response prevention, or ERP. ERP deliberately creates a fear hierarchy. A therapist guides the patient through gradual exposure to their specific triggers, but strictly prevents them from acting out their compulsive response. Over time, the brain naturally achieves what's called habituation, literally retraining its own circuitry so it no longer sounds the panic alarm. Now, alongside ERP, medications play a massive role as a first-line treatment. We're primarily looking at SSRIs like fluoxetine, sertraline, fluvoxamine, and escitalopram, as well as clomipramine. These work directly on those chemical imbalances we talked about earlier. But the absolute critical takeaway here is adherence. Patients usually require an adequate duration of treatment, often months, and strict adherence for these meds to properly do their job and balance the brain's chemistry. Of course, evidence-based treatment doesn't just stop at the clinic door. A huge part of this is comprehensive lifestyle and rehabilitation management. Regular exercise, rigorous sleep hygiene, stress reduction, and mindfulness are absolutely essential. Furthermore, educating the family so they don't accidentally accommodate the patient's compulsions, along with cognitive and occupational rehabilitation, plays a massive role in preventing long-term relapse. All of this science leads us to real patients finding real hope and genuine clinical success. When we look at how these interventions play out in the real world, it's incredibly inspiring because highly tailored care absolutely works. For instance, Case 1 highlights a young adult who completely conquered their contamination fears using a combo of ERP and an SSRI. Case 2 shows a student who saved their academic career from debilitating checking compulsions by utilizing CBT. And even in Case 4, where someone had severe treatment-resistant OCD, they still found profound relief through specialist medication augmentation and intensive ERP therapy. The really wonderful news here is that there's no guesswork. All the major international health organizations, from the WHO to the APA to the International OCD Foundation, are in complete agreement on these protocols. They universally emphasize early recognition, using ERP and SSRIs as first-line treatments, combined therapy for moderate to severe cases, and crucially, that reducing public stigma is just as important as the medicine itself. I want to leave you with this exact, powerful conclusion drawn directly from our source material, because it perfectly validates the reality of the patient experience. Quote, "Obsessive-compulsive disorder is a real, common, and highly treatable medical condition. Intrusive thoughts do not define a person's character, and compulsions are not a sign of weakness." So I leave you with this question to chew on. With everything we've uncovered today about the intense physical neurobiology of OCD, how will you change the way you view and support mental health in your own community? Think about it, and let's keep learning together.